Hello, and welcome to our webinar this afternoon on research and clinical advances in LSVT LOUD and LSVT BIG. We're thrilled to have you all with us today for what is our last webinar of our 2018 series. And so it's been a great year of sharing information with our LSVT certified clinicians, with members of the public such as yourselves. And so we're thrilled to wrap up the year by sharing some new exciting advances, both research-wise as well as clinically. My name is Cynthia Fox. I'm one of the presenters here today, along with my colleague, Heather Cianci. We always like to begin by acknowledging our research support that we've had over the years, which is especially salient on a topic like this, that is about our research. So we've been funded for many years from the National Institutes of Health, as well as a number of other foundations listed here, and that has allowed us to be able to advance both the research and clinical practice of LSVT LOUD and LSVT BIG. I share with you our disclosures. Myself and Heather both have financial and non-financial relationships with LSVT Global. Non-financial includes a preference for LSVT BIG and LSVT LOUD as treatment techniques. Myself, I'm an employee of LSVT Global. I receive lecture honorariums, as well as I have ownership interest in the company. And Heather is a consultant for LSVT Global, one of our fabulous LSVT BIG faculty, and she receives lecture honorarium, consulting fees, and travel reimbursement. So our plan this afternoon is to quickly go through a few logistics. We'll present the content of the webinar. At the end, we'll have the ability to address your questions, but please note at any time a question pops in your head as we go through the presentation, you can go ahead and type that in your question chat box, and that simply gets into the queue of questions that we'll address at the very end. There's a handout that was emailed to you prior to the presentation. You also have a link to that in your panel view there that you can download or save should you want to have the material for later. And finally, at the end, when you close out of the webinar, it will automatically launch a very short surveys. It should take you 2 minutes or less. And if you can take a few moments and fill that out, that information is very valuable to us to understand what we can do better in our webinars and also potentially what additional topics you'd like to have us cover in the future. For those of you who report continuing education activity, a few quick notes. The webinar is not either ASHA or PTOT state registered for CEUs, but you can use it for self-reported as non-registered CEU activity. So if you are a speech, physical, or occupational therapy professional and you would like to self-report your activity for attending this live event, email us after the presentation at webinars@lsvtglobal.com. Request a certificate for the webinar, include your name, date, and duration that you attended the webinar. Licensing requirements for CEUs differ by state, so always check with your state licensing board to determine if they accept non-ASHA registered CEUs. And attendance for the full hour is required to achieve that certificate. Our bios of who we are listed here. I will not read all this. In very short, I'm a speech language pathologist. I've been part of LSVT for nearly 25 years. I have extensively worked with LSVT LOUD and also worked on the development from LSVT LOUD to LSVT BIG. And I currently serve as a faculty for both courses as well as vice president of operations for the company. Heather is one of our expert physical therapists, and she is a founding therapist of the Dan Aaron Parkinson's Rehab Center at Pennsylvania Hospital in Philadelphia. And so she has been part of our team for many years, and again, is one of our LSVT BIG faculty, has an expertise not just in Parkinson's disease, but also other neurological disorders. And we'll hear from Heather a little later in the presentation. So now I'm going to launch our first polling question, and this allows you to have a little bit of participation. And what we'd really like to know is basically who are you? And so, okay, yeah, I think you should be able to see right now the opportunities to tell us if you're a speech therapist, physical or occupational therapist, perhaps a person with Parkinson's disease, a family or friend of a person with Parkinson's disease, or perhaps another category that we could not fit. I believe we're limited to 5 choices. So we go with our most common and then add in others. So I'll give just a few moments and we'll see. Looks like we have a nice mix. We have quite a few speech therapists, physical and occupational therapists, a good percentage of people with Parkinson's disease, and a percentage in the other category, which could be a whole range of choices. So again, welcome, and we're really thrilled to have all of you here with us. Let me get back to the slides. Okay. All right, so our objectives for this afternoon are as follows. We want to briefly provide a framework for the importance of research and how to evaluate research evidence. Then we'll briefly review some of our foundational LSVT LOUD and LSVT BIG research, which will lead us to our sort of meat of the presentation, which is updating you on new research that's come out in 2018. Given our time constraint, we can't go through all the publications, but we selected a few to highlight and have provided you references to the others. And then we'll use that research as a framework to really highlight clinical advances and things that we know are important as therapists and as people with Parkinson's disease to emphasize during LSVT LOUD and LSVT BIG practice. And finally, we'll just summarize some of our future research and clinical innovations. So as we know, up to 8 million people worldwide are living with Parkinson's disease. And unfortunately, this prevalence is expected to double by 2040. So there is a great need for effective treatments that go beyond traditional pharmacological and neurosurgical, but also encompass rehabilitation or speech, physical, and occupational therapies. Our mission at LSVT Global is twofold. One, to empower people with Parkinson's to restore and maintain their highest levels of functional communication, mobility, and independence with activities of daily living through scientifically supportive rehabilitative treatment programs, and specifically LSVT LOUD and LSVT BIG. We are assuming today that there's some basic knowledge in the audience of what these treatments are. If anybody is very new or naive to them, we have a wealth of other webinars on demand that go into great details, the specifics of the treatments and the exercises and things like that. In terms of therapists, we know that research is essential to provide that strong foundation we need as therapists to have confidence in the treatments that we deliver. So this leads us to this concept of evidence-based practice. And its definition is that evidence-based practice includes the integration of the best available research as a hallmark, clinical expertise, and patient values and circumstances related to patient and client management, practice management, and health policy decision making. So from a therapist's perspective, we need to consider, do the treatments we're delivering have quality evidence as one of those key tenets of evidence-based practice? And do we choose interventions that have been researched? And if they have, do we deliver that intervention as it was delivered in the research study? So keeping the same methodology, dosage, and intensity. From a consumer or patient perspective, we want to think about, are the treatments being offered to us, ones with quality evidence? And if they are, and therapists tell us they're giving us evidence-based treatments, is the therapist or the facility providing the therapy maintaining, again, that methodology, that dosage, that intensity that was achieved or delivered in the research studies? And this is kind of a classic challenge. So you see, on the right, that ivory tower research lab where the research and the evidence is produced and published in the journals. And as NIH has defined it, oftentimes there's this valley of death in terms of the translation of those discoveries into real-world clinical trenches where therapists are implementing them and patient populations. And so LSVT Global is highly committed to not allowing the science that we've created fall into that valley of death. And when that happens, we lose the ability to implement or loss the fidelity of treatment. So we're committed to maintaining the same quality of treatment that was delivered in our research studies into clinical practice. And it's not easy, but we want to try to provide patients with the best quality possible. So other considerations, again, whether you're a therapist or a person with Parkinson's disease or a family member, when thinking about evidence-based treatments, you know, do we decide basically on the amount of research? Is it the quality of research? Is it more important to think about, well, is that feasible for me or my patient? Is it reimbursable? As a therapist, am I skilled to deliver this treatment? Will the person with Parkinson's disease like it? What about interventions that are offered that are not evidence-based? And are there ethical or safety issues? And we'll not delve into each of these questions and issues in this 1 hour. Rather, we hope that the research update and clinical advances that we're providing kind of give you a framework for thinking through these questions so that we can really have research and clinical advances guide decision-making, both for therapists and for people living with Parkinson's disease, so that we don't have a knee-jerk reaction to revert to unproven methodologies, sometimes simply out of convenience. So in terms of models of research, there are phases that are typically processed, whether this is, again, a pharmacological treatment or a behavioral outcome. So phase 1 is simply detect the presence of a therapeutic effect. In phase 2, you're going to define and refine that. These are typically case studies, single subject designs, small group designs with variable controls. Phase 3 is really when the rubber hits the road and you test the efficacy of a treatment through a randomized controlled trial. Phase 4 then, if the treatment passes efficacy, goes into real world practice as well as generalization to standard scope of practice in phase 5. In addition to processing through those phases, the classes of evidence evaluate the quality of the research. There are many, many classes of evidence, and this is just one example, where 1A class is a meta-analysis of multiple well-designed studies, and that's the highest level in this classification. Level 1 is a well-designed randomized controlled trial. Level 2, well-designed non-randomized controlled trial. Level 3, observational studies with controls. And level 4, observational studies without controls. So even within those classes then, you may be thinking, well, how do they determine quality? Well, some of the studies may be rated on qualities such as listed at the bottom of the slide there. Was there random allocation? Were the baseline characteristics comparable? Were therapists blinded to the treatments they were delivered, or assessors blinded to the condition of the people they're assessing? So there's a lot of different characteristics that are used in standardized fashions to determine evidence quality. Now, you may be overwhelmed thinking, I don't know how to do that. I don't have time to do that. And that's fine, because there are several independent, non-biased reviews out there that have done it for you. In the area of speech-language pathology, we direct you to the ASHA, which is the American Speech Language Hearing Association evidence maps. And within these maps, it actually includes more than just voice treatment, but motor speech language, categories, and you can search within there what you're interested. What I've screenshotted here is Parkinson's disease. And so if you recall in the previous slide where meta-analysis were the highest level of evidence, In the ASHA evidence maps, they only include meta-analysis and therapeutic guidelines. So they've done some of the groundwork for you. And it's a nice way to step into to start to think about quality of evidence of treatments that are out there. Similarly, there are these independent reviews for physical and occupational therapy. For occupational therapy, it's the OT Seeker, which again is a database that contains randomized controlled trials. And for for physical therapy, one example is Pedro, and it's a physical therapy evidence database. Within each of these, again, you can enter search parameters that will narrow your search to what you're interested in. In terms of the Pedro study, just for example, I pulled up our randomized controlled trial in LSVT Big, and what you see are some of those eligibility criteria for evaluating quality of evidence. And it received a 6 out of 10, which would be considered moderate quality evidence. And if you go through, for example, we met the criteria for random allocation, concealed allocation, no. Baseline comparability, yes. Blinded subjects, no. And so that just gives you a sense of how these quality determinations are made related to evidence and these research studies. So our work with LSVT LOUD has been, and LSVT Big has been a 25+ year journey. And I'm just highlighting sort of the level of studies we've done. You see the 3 orange randomized controlled trials that were done in LSVT LOUD, as well as when LSVT Big development began and when that first LSVT Big randomized controlled trial was published. We don't want to spend a lot of time on the historical or foundational research, but I think it is important to highlight a few of the key studies. So this was our first LSVT LOUD randomized controlled trial. The first set of data, which was immediately post and 6-month data, were published in 1995. What you see here is publication of our 2-year follow-up data. In short, the blue line is for LSVT LOUD. The red line was for an alternative matched treatment approach called high effort respiratory treatment. Looking pre-post out to 2 years later, decibels of sound pressure level, so that's on the y-axis, the higher up, the louder the voice, in 2 tasks, reading and monologue. Overall, what we found was the group that received LSVT was statistically louder immediately post and actually maintained those improvements out to 2 years after treatment. This was the first study to show that speech treatment could work and last in people with Parkinson's. Because LSVT was superior in the previous trial, in our second randomized controlled trial, we compared LSVT LOUD to untreated controls. So what happens, and really at the time we did the study, that was probably pretty close to usual care because a lot of people did not receive referrals for speech. And same setup in terms of blue is LSVT, red is respiratory. And we saw that the LSVT group versus untreated, again, statistically significantly improved their loudness and maintained that, in this case, our follow-up, excuse me, was out to 6 months. Our first randomized controlled trial for LSVT Big was entitled the Berlin Big Study because it came out of Berlin. Dr. George Ebersbach was the first author. In this study, we had 60 patients who were randomized to one of 3 treatment groups, LSVT Big, Nordic walking, which was considered usual care, or home exercises. They were measured at baseline, immediately post-treatment, and at a 16-week follow-up. The primary outcome variable in this study was a change on the United Parkinson's Disease rating scale motor score, which was rated by blinded assessors. In this measure, a decrease is actually an improvement. So in the solid black line, we see the home group. The dotted line, we see the Nordic walking group, and there was no changes in those 2 groups on this measure over time. In contrast, in the dashed line, we see a significant improvement immediately post and at 16 weeks later following LSVT Big. For additional resources to review all the foundational LSVT LOUD and LSVT BIG research, I give you 2 locations. On our blog, on our research, you can access many of these references and in some cases, the open access articles. You can access the blog directly through the email address there or by going to our homepage, and there's a link at the top of the page for blog. The ASHA journals has also published a special collection specifically for key LSVT LOUD studies that have been published in ASHA journals, and all of the articles in that collection are what we call open access, which means you can freely download the article and have that to read and review as you please. Okay, so now that we've gotten through sort of understanding the foundation for research and how research data are analyzed for quality, a little bit of the foundational research, let's dig into what's new. So one of the articles that we absolutely want to highlight for 2018 is our 3rd randomized controlled trial. This is very exciting. That was published just at the end of September of this year in the Movement Disorder Journal. First author, Dr. Lorraine Ramig. The objective of this study was to evaluate 2 speech treatments for Parkinson's disease that were matched in intensive dosage and high effort mode of delivery, but differed in the subsystem they targeted. So either voice, which really targets the respiratory laryngeal system, and this is LSVT LOUD, versus articulation, which targeted the oral facial articulatory system and was called LSVT ARTIC. Our measurements for sound pressure level, which is a measure of vocal loudness across a range of speaking tasks, and a self-reported communicative effectiveness scale. So this is the participant's impression of changes in communicative effectiveness after therapy. And it was administered to 20 healthy controls and 64 patients with Parkinson's disease. People with Parkinson's disease were randomized to either LSVT LOUD, LSVT ARTIC, or no treatment and studied at baseline, 1 month, which was immediately post-treatment, and 7 months later. This study flow chart shows how subjects moved through the study and is consistent with consort guidelines. And consort guidelines are today's standard for guidelines on how to run randomized controlled trials. I won't go through all the detail, but you can see the flow through the study where we had 106 that were phone screened, a clinical assessment where some of the individuals did not qualify. We ended up randomizing 64 individuals with Parkinson's disease and 20 healthy comparison. And we did our baseline, patient allocation, treatment was delivered to the 2 treatment groups, post-treatment data immediately 1 month post-treatment, and our 7-month or 6-month post-treatment follow-up. In terms of what was done in the 2 different treatments, LSVT LOUD versus LSVT ARTIC, this is a very detailed treatment chart. So for those of you who are quite curious, I encourage you to download the article and read it. And we have on one column everything we did in LSVT LOUD, and then on the second column, everything that paralleled in great detail, with the exception of the target, what we did in LSVT ARTIC. So what did we find? Our primary outcome variable was change in sound pressure level, again, which is a measure of vocal loudness, from baseline to 7 months post-treatment. And here we see on the x-axis time, baseline 1 month, 7 months. On the y-axis, again, those decibels of sound pressure level, so the higher the line, the louder the voice. And we see in the dashed line, or dotted line, untreated Parkinson individuals who did not change over time. The dashed line, the LSVT ARTIC group, compared to their pre-treatment level, had a statistically significant improvement immediately post, but it was not maintained at 7 months. LSVT LOUD had a statistically significant increase in vocal loudness immediately post that was maintained at that 7-month mark. The secondary outcome variable was changed in the self-reported communicative effectiveness scale, and same setup in terms of time, scale on the y-axis, 0 is worse, up to 100, which is best. And similar findings in terms of both LSVT LOUD and LSVT RTIC impacted positive improvements in communicative effectiveness in people who participated in the study. However, at 7 months, only the group that received LSVT LOUD maintained those positive gains. So the conclusions of this study were that this RCT contributes to closing the knowledge gap on effective speech treatments for Parkinson's, and it provides additional support for voice LSVT LOUD as an efficacious target when delivered intensively in the treatment of speech in people with Parkinson's disease. And we found that only LSVT LOUD affected improvements that were maintained out to 7 months for both SPL and self-reported communication. So voice may be uniquely beneficial in improving speech production in people with Parkinson's. And LSVT LOUD is the only speech treatment with 3 randomized controlled trials documenting short and long-term efficacy. Okay, so the final LSVT LOUD study that I'll share with you before I turn it over to Heather is looking at neural correlates of hypokinetic dysarthria and mechanisms of effective voice treatment in Parkinson's disease. The objective of this study was to specify cerebral pathophysiology of hypokinetic dysarthria and treatment-induced changes using fMRI. Baumann was the first author of this study, and this group was in Germany. So they used fMRI, which is a neural imaging technique, in 11 healthy controls and 11 patients with idiopathic Parkinson's disease before and after treatment with LSVT LOUD. Measured fMRI during covert reading, so that's mentally reading without actually moving one's mouth, so you reduce movement artifacts, and 2 conditions: normal, which was defined as conversation in a quiet room, and high, which was defined as shouting on a windy beach. They tested effects on intelligibility to see if behaviorally the treatment worked, and as well as fMRI. So in terms of behavioral outcomes, these are looking at what we call vowel triangles, and it's a measure of articulation. And in the black is the vowel triangle for non-Parkinson individuals. In the green is the pre-treated Parkinson individuals. This is very classic. You see that green triangle is smaller, which is consistent with poor articulation. After treatment, that red triangle is larger and more closely matches the black triangle. So an improvement in articulation. So behaviorally, the treatment worked. So what happened in the brain? Well, on the top row, what you see is the activation pattern of the high intensity or louder covert reading in both control and Parkinson individuals. And in the B, the second line, what we see is the LSVT-induced signal increased in right temporal area and the right supramarginal gyrus during normal intensity. So what that means is LSVT led to a partial transfer of that cortical activation pattern for high intensity that you see in the top row into normal speech post-treatment. So in conclusion, they determined that hypokinetic dysarthria in people with Parkinson's may be due to a dysfunction of mesial frontostriatal neuronal networks. What's interesting is that for both Parkinson's and healthy, there was this increased intensity in the right temporal parietal networks, which are engaged during prosodic elements of speech, and that would include things like louder speech. Effective LSVT LOUD then may be explained by this increased recruitment of these right-sided networks for high-intensity speech during normal conversational levels post-treatment. And what's exciting is that these findings are very consistent with previous PET studies in that we see this right-sided shift to areas of the brain that are important for these suprasegmental features of speech, and that right temporal activation may be related to increased self-monitoring and feedback regulation. So not only do we see that third randomized controlled trial, but we're seeing neural evidence for why the treatment works. The last slide I'll share with you is some other publications. So you'll have this in your handout across a range of other topics. Neuroimaging data in a different population, children with cerebral palsy and dysarthria, the impact of LSVT loud in Spanish speakers on swallowing, and technology-enhanced delivery of LSVT loud. So with that exciting roundup of some of the things that are new in LSVT loud research, I'll now turn it over to Heather, who will update us on what's new in LSVT Big.
Great, thank you so much, Cynthia. So many wonderful studies are coming to the forefront with both LSVT loud and LSVT big. It's really a great time to be working in this population. So one of the studies that I'm going to start with here is known as the JFK Big study, and this was done by therapists who are working out of the JFK Center, and they were looking to see if LSVT big was having a positive impact on decreasing hypokinesia. So we know that the hypokinesia, that smallness of movement, makes it very challenging for patients to do tasks. And they were looking to see if that could decrease the negative impact of the hypokinesia on dual task performance, so having people do more than one thing. And what they did was they did a retrospective chart review. So that means they looked back at patients who had already gone through the program, and they were looking at a number of measures, and those were pre and post test of something called the timed up and go. And if you're not familiar with the timed up and go, that's a test where PTs and OTs ask someone to stand up from a chair, walk a certain distance, about 3 meters, about 10 feet, turn around, come back to the chair, turn around and sit. So it encompasses a lot of movement. And then we ask people to do something where they are doing a dual motor task. So where they are saying some words out loud, where they are counting, and then also that motor task where perhaps they're holding a glass of water. Those are the common ones. So they did this study where they looked back at it, and let's look at the next slide and I'll share with you some of the outcomes. This was wonderful in that it really showed that there were true improvements in these patients' abilities post LSVT big, so after they completed the program. And what you're looking at here are the scores in this red box of where people were with doing the regular tug, the tug with the dual cognitive task, as well as the tug with the motor task. And you can see how those numbers really went down, and that's a positive. That means that the patients were moving with a faster speed, a better quality of speed, and that the cost of difficulty with those patients' ability to do that also went down. Now, if we look at the next slide, the thing that's even more impressive about this study is that people were able to continue these things going. So what you're looking at here again is how the LSVT big intervention really was able to substantially decrease the tug motor and tug dual task cost. And that means that those patients, it wasn't so much of an effort for them anymore. These things were coming a little bit more automatically for them, and it wasn't as challenging. And in that next slide, we're going to show that not only were patients able to do this at the 4-week mark, so after they were done with their LSVT big, but they maintained it out longer than that. So let's take a look at that next slide. Oh, and I'm sorry, I don't have that on there. I'm thinking ahead in my mind. It actually showed that those people were able to maintain that out to 12 weeks. And that's really important because we don't say that people just get better with LSVT big and that's the end of it. This study really did help to show that people were able to maintain that level, and it showed that it kept them in that lower level of fall risk, which is so important. So let's go back to that conclusion slide here. And it says that really it's showing and suggesting that the cueing strategies that are associated with LSVT big really have become more internalized. So the patients are not having to think about them so much. It's more of a normal thing for them. And they're able to decrease that negative impact of the hypokinesia on not only mobility, but also their cognitive performance when they're doing 2 things at once. Now, while this study was very impressive, some of the limitations were that it was uncontrolled. The therapist who actually did the treatment of the patient also was the therapist who were collecting the data. We'd love to see more length and time of the follow-up, and there really wasn't a standardized measure of what the disease severity was, so knowing where patients were. So again, lots of good research that's coming out. Another one here was, how did LSVT Big impact postural control for people with Parkinson's? And this was a case study. And they looked at individuals with moderate Parkinson's disease, so in stage 3, people that were having symptoms on both sides of the body and still also having problems with some gait and some walking. And they looked at several measures, so they were looking at balance, how people were walking, again, their ability to perform 2 tasks at once, their quality of life, and then also their confidence in their balance. So they did that immediately post, meaning they looked back at that patient's chart, and then prospectively that follow-up again at 1 month and 4 months later. So let's take a look at the next slide and we'll talk more about what they were finding. The nice thing about this program of using LSVT Big is it's not just exercises, it's truly looking at the quality of functional mobility, of activities of daily living, and of things people want to do. So you can see some of the functional component tasks. Patient 1, being able to button, being able to fold laundry, hierarchy tasks of still being able to travel and walk outdoors. Now, each of these 3 clients did have some complications. The first one had some issues with changes in medication, fatigue, and stress. Patient number 2 actually had to make the choice to stop driving, and client number 3 was having difficulty with work-life balance and stress management. But again, in patient 2 and 3, you can see there are a lot of great functional things there, as well as writing, being able to get in and out of bed, sailing, cutting food, and the ability to type. Next slide. So the changes in the measurements of these 3 clients we're looking at before LSVT Big, after LSVT Big, so that's at the 4-week mark, then at an 8-week mark, and then at a 20-week mark. And again, this shows a beautiful improvement here in that timed up and go with the dual cognitive task. So you can see, let's take a look at patient number 1. You can see that patient went from a score of 24 seconds all the way down to 11 seconds. And if you notice and look at all of the follow-ups for all 3 people at week 20, they were able to maintain that gain. So again, their ability to be able to keep doing dual tasks, have quality of gait and balance, and reduce their amount of fall risk, even 20 weeks out, is remarkable. So it's really showing us clinically meaningful improvements with gait and balance when they're doing dual tasks, and that they were able to keep that out. The one thing what was not observed in this, and you would hope to see that, but it's just something that didn't kind of flush through in this, were changes in quality of life. Next slide. So when we're thinking about what's the conclusion of this, what we're coming up with is that LSVT Big therapy may actually improve postural control, so that balance, gait, and dual task performance, and then therefore can really reduce the fall risk for people with Parkinson's disease. And that is something that is just at the front of our minds all the time as physical and occupational therapists. Again, some limitations with this. It was again, a case series, uncontrolled. And once again, the therapist who were the treating therapist also did collect the data. Next slide. This is a great study because oftentimes we are asked, can you use LSVT Big in someone who doesn't have Parkinson's disease? And this is a great study showing that they worked with an individual who had had a stroke. And this client was able to go through the full program of 4 times a week for 4 weeks, but then also had an additional way of performing the home exercise programs by using something called the Mystic Isle platform. And that was using Microsoft Kinect sensor. So a lot of people know about the Microsoft Kinect gaming system. And that was a way for them to track how the patient and how often the patient was doing the exercises at home. And the nice thing when they were able to look back on that was found that the intensity of using LSVT Big coupled with the integrated neuroplasticity principles about how we push people, how we make actual brain changes, plus the ability to use that game-based delivery system really did lead to the patient making gains that were far beyond what the therapist had expected as well as what the client had expected. And moreover, she was really able to maintain most of those gains after 6 weeks with no treatment, so just on her own. Her name in the case study here is Brenda. That is not her real name, but they say that the improvements that Brenda made in her performance of occupations and engagement in new occupations really do reflect the saliency of LSVT Big intervention. because what they worked on with her were things that she wanted to improve on. And we know that people are much more motivated and that we will do better when we do the things that we like to do and things that we want to do. Next slide. Some other publications that we have there, and I'll just briefly touch upon them. The first one here is the use of a telehealth system, again, to improve a patient's program at home. And again, it was found that the telehealth is really kind of an up-and-coming new way where we can help patients to really improve their motivation. And if we can get people to continue to do their program after they're actually done therapy, that's going to be very advantageous for them, because we know if someone just stopped taking their medication, that there would be changes. And we really need to think about exercise and functional mobility in the same way. If we stop practicing it and stop doing it, there's going to be a decline. The next one on here looked at a kind of a review and a meta-analysis of research that's out there supporting LSVT Big. And what they're finding was, again, that LSVT Big was superior to a shorter program. So not doing the 4 times a week for 4 weeks did not give the same improvements. And finding that LSVT Big is also superior to a generalized exercise program for someone with Parkinson's. The third one here was looking at how LSVT Big can improve the speed of someone's gait, their balance, their rating on a test that the doctors do. It's called the UPDRS, the Unified Parkinson's Disease Rating Scale, as well as quality of life. And the difference with this is that they were looking for people in stage 1. So that means people who are in very early stages of the disease may actually still be functionally independent and not thinking that they have a lot of problems. And sort of as Cynthia had said earlier, you know, people may not have been getting LSVT loud early enough. That has long been the problem for our patients with PD with LSVT Big, with them not getting PT and OT loud enough. This study was great in that it showed that you can still have an impact on the functional ability of people even in the very early stages, and that we as therapists really do need to continue to work with folks and to come up with some new ways that we can test them and capture these changes. And the last study here was looking at patients who were more into the middle stages of the disease and were having what is known as wearing off. And that means that the medications were not lasting as long as they normally do over time. And we know that when people are wearing off, their mobility can get much stickier, much more anxiety can be involved. There's an increased chance of falls and things not working so well during wearing off. So they actually found that the folks who went through this actually showed an improvement in their ability on the activities of daily living scale 12 weeks out. So even after the study, the active portion of the study had concluded, patients were still gaining improvements, and there was a tendency for a very small improvement in the amount of off time, and that it wasn't as long as it was at the start. Next slide. So we want to step back and think about, from what Cynthia had said and the research that I just talked about, you know, how do we highlight these advances and then move forward with improving both LSVT Loud and LSVT Big in practice? You know, how do your therapists use this and take it into the clinic? So not only do these clinical advances entail research, meaning that it's research that's specific to LSVT Loud and LSVT Big, but also general research on Parkinson's disease and on things like motor learning and neuroplasticity. But it's also our clinical experience. So when we couple those two things together, we can truly see that these advances can help us to highlight that there are key components that we as therapists need to emphasize even more for you during your therapy. So we're thinking about personalized care, and that means the focus is on a function, on making you move better and feel better, and on focusing on personalizing everything to your needs. We use the word protocol, but it truly is not a cookie cutter approach. We are individualizing these treatment sessions to whatever your needs are. The other thing is maintenance. As I mentioned before, we have to have a lifelong practice of doing our exercises, just like a lifelong program of the medications is important. And then lastly, we want to think about the non-motor symptoms. And I often have patients who will say to me, you know, I think I can manage these motor symptoms. I'm doing okay with those, but these non-motor symptoms, the problems with my mood and the sleepiness that I feel and the difficulty that I'm having in other parts of my life, you know, I wish there was something we can do. And we're now finally showing that the research is saying that LSVT Big and Loud can be helpful. So please do consider, if you're a therapist, the role that we can have using both LSVT Loud and LSVT Big on helping patients with the non-motor symptoms. Next slide. And we ask, can you achieve a person-centered care in something that is standardized and evidence-based? And the answer is absolutely yes, you can. And that is because if you have met one person with Parkinson's disease, you have met one person with Parkinson. Everyone is different. Everyone comes to this disease with a lifetime of experience and different things that are important to them. So if you are somebody who wants to continue to get together with your friends and play bridge, the ability to simply be able to dress oneself, to be able to walk, to hike outside, to be able to get up out of a chair without help, you know, that's how we're going to focus on that, because it's a functional application of what we're doing. It isn't just about the exercises. It's about helping you to move your best, to speak your best, and to be as functional as possible in everyday life. Next slide. And the way that we help you to stay functional is that we really do choose tasks that are salient, meaning they're very important to you, and they're things that are engaging to you. And I gave an example the other day when I was giving this webinar to some other therapists, was that if I had to do some work and someone said to me, you know, Heather, we want you to work on redoing the carburetor and the brakes on a car, and we think you'd be really good for car repairs, I would do a double take and say, no, I'm not interested in that at all. Now, if they said to me, we want you to be able to get out there and learn about historical tours and to be able to teach people about different history in Philadelphia, that's something I'm really into. So if you were to make my program around history, I would be very motivated to do that. So we have to link what we're doing to your functional goals that are personalized just to you. So it's not just about the activities of getting out of a chair, being able to dress oneself. It's also your hobbies. It's also passions. And they are things that help you to self-realize who you are with your communication, with your function, and just in everyday life to be the person that you want to be. Next slide. So we always want to tell everyone, and this is important for therapists and for people living with Parkinson's as well, after those sessions end, so after treatment, we really have to make sure that our clients are taking their daily dose of both LSVT Loud and LSVT Big homework exercises. So the optimal, the best combination for success is optimal medication, followed by using those LSVT Loud program and using the LSVT Big program so that we're keeping the function alive in our patients. Next slide. And we know that it doesn't just end with the 4-week program when you're with us. It really is lifelong support, and trying to help people understand how to practice and keep that going. We have LSVT homework helper videos, and we also have an LSVT companion client edition. So there are different ways for people to be able to watch the exercises, hear voices, and help them to feel motivated. There's also new group exercise options, and I'm going to speak a little bit about Loud for Life as well as Big for Life in an upcoming slide. But also remember, if you're someone living with Parkinson's disease, that it's absolutely important that it's not a once and done. You have to go back and see your speech language pathologist, occupational therapist, or physical therapist pretty regularly, about every 3 to 6 to 12 months, because Parkinson's is a progressive disease and we want to be there with you throughout that lifelong journey of living with it. And we also really want to promote you to get out there and do other enjoyable activities. So taking a new pottery class, you know, going to concerts that you may not have wanted to go to before, and finding other options for you that'll really help you to enjoy your life. Next slide. So Loud for Life and Big for Life, these are group exercise classes, and they are considered maintenance classes. So that means these are for people who have already completed the entire LSVT Loud or the LSVT Big protocol. So you have to have gone through that with your therapist first before you can enter into a Loud for Life or Big for Life class. And the next slide, I'm going to talk to you a little bit about what that is. And again, I said that it was community-based. It's going to be led only by certified clinicians in LSVT Loud or LSVT Big, and we kind of act as your fitness professional. So these classes are not led at this point by personal trainers. They are actually led by therapists. It's a cash-based system, so unfortunately, insurance companies do not cover this at this time. Most of these classes are quite reasonable and nominally charged, so it's a nice way of staying active and connected. So let's look at the next slide and help you to understand that this is not, though, skilled therapy. This does not take the place of PT, OT, or speech. So when you go to therapy and you go to this class, the therapist should not be billing. This is not for people who haven't received LSVT Big or LSVT Loud yet. You have to have graduated from the program, and it doesn't serve as a replacement. If you really want to get the most bang for your buck and really keep this going beautifully, it has to be both together. Next slide. So we know that it can be very challenging for individuals living with Parkinson's disease. There are many, many things that complicate the situation, not just of the motor symptoms, but also the non-motor symptoms. And people suffer from things like fatigue, excessive daytime sleepiness. There are problems with depression and anxiety, and sometimes those things can be there even for several years before you've actually seen some of the motor symptoms that are coming out. Apathy is a very challenging situation where people sort of lose their zest or their zeal and just can't get motivated to do things. And we really feel that we can help to motivate and engage people by really putting together some collective strategies so we can overlap with both LSVT Loud and LSVT Big. So we're going to give you positive reinforcement. We're going to say to you, when you tell us that the exercises are hard, we're going to say, yep, they are, but this is going to help to improve your communication and your movement, and it's going to give you the confidence when you're walking and you're talking, and you have really important things to do and say in your life, and we need to keep you active. So we're going to encourage you to be energetic in your participation after graduation, and really knowing that there is a role to really get systems motivated. This is a great quote from local therapists who have said, in working with someone to help motivate, what makes us the happiest to see is how much his demeanor has changed. When we started, he wore a baseball cap, pulled down low over his eyes, and did not joke or smile. But now he stopped wearing the hat, jokes and laughs all the time, and walks with his head held high. So you can see the changes in that person's life. The next slide we have is from an LSVT Loud clinician, where they say, I do believe that as patients begin to see positive results from therapy and hear positive comments from others, their confidence also increases, which impacts their ability to cope with anxiety, depression, and apathy, and many other things much better. So we're hearing from therapists out in the community about the improvements, but we're also hearing from clients living with Parkinson's disease, and that's wonderful too, because before treatment, we know that those slow, small movements and that quiet voice can lead to people feeling less confidence and not really attaining success. And that may actually cause people to withdraw from what they're doing. What we're looking for is that after treatment, people now are having bigger, more normal movements, louder, more normal volume of their voice, and that the program that we gave them, again, was intense enough and important enough that they're going to feel like they're making success, and they're going to be less withdrawn and then more confident to be able to participate in life. So giving one back the ability to feel in control is something that we take very seriously with LSVT Loud and LSVT Big. Next slide. And here is that client testimonial, Christopher B., where he says, LSVT Big is my miracle. I was diagnosed around my 41st birthday, but on my birthday this year, the big 45, I gained back my balance and a lot of mobility back. I am excited and want to share my hope with others. And that word hope is something we really want to emphasize with this program. So in summary, it really is essential that our field in the rehabilitative sciences, that we develop research-based treatments that are based on really solid evidence and theory. However, you as therapists, can you have the best model and theory in the world, but it is crucial question is, can therapists implement it? And you as people living with Parkinson's, can you participate in it? And the answer about what is unique about both LSVT Loud and LSVT Big is truly that the answer is yes. LSVT can truly help people with early through late stage disease. And LSVT research, outcomes, and clinical knowledge are really feeding successful implementation. And as a result, people with Parkinson's are really benefiting from these quality treatments with their therapists. And we are thanking you for taking time, because we know that this webinar really did help to provide you with an update on the latest findings and the positions for both research and clinical advances that really will help with therapists implementing and having an easier time with this. So I'm going to turn this over now to Dr. Cynthia Fox, let her talk about future research, and then we will go on to answer some questions.
Thank you so much, Heather. So while we have a lot of exciting research that has happened over the past 2 years, there's always more to be done. Some of the data from the randomized controlled trial that we presented on LSVT LOUD versus ARTIC versus untreated, we used the current publication is our primary outcome variable of SPL and communicative effectiveness. But we have in the wings a lot of data that we presented at various meetings that were ready for publication. This is looking at speech intelligibility as well as speech intelligibility and noise, facial expression, the impact on swallowing, the impact on language output, as well as an additional imaging study that has taken imaging of the 3 different groups, LSVT LOUD versus ARTIC versus healthy controls, and not just pre-post, but adding a 6-month follow-up. We're looking for the next RCT randomized controlled trial of LSVT BIG, where we believe comparing it now to another type of evidence-based approach will help to flesh out what are the features of each treatment that perhaps target specific elements of functioning for people with Parkinson's, which can help us better determine prognostic variables, as well as looking systematically at the impact of LSVT BIG on fall prevention. Prospective studies that look ahead and include non-motor scales before and after LSVT LOUD and LSVT BIG, where we could systematically measure, are there changes in things such as anxiety and apathy. Continued studies for technology, enhanced LSVT LOUD, LSVT BIG, really studying the impact of these maintenance groups, BIG for life and LOUD for life, on our long-term outcomes. And then finally, additional clinical implementation studies. So hopefully next year or the year after, we'll have some updates on some of these topics to be able to provide. Oops. Okay, so now it's time to open the floor up for questions, and we have a few minutes left here that we can take some questions. Again, you can type your question in the control box, and I'll see it here and be able to read it aloud. Or if you're comfortable speaking in the microphone, you can click your hand and we can unmute your microphone. If at any time after this webinar a question comes to mind, you can always email it to us at info@lsvtglobal.com, and we're happy to answer that question for you. So the first questions we received is this: has there been any correlation to patients who are using LSVT LOUD or LSVT BIG and having support person at home or not having support? So I'll speak first, and then I'll open it up for Heather. At one level, one of our goals in treatment is really to empower the person with Parkinson's disease. And that idea becomes they are responsible for their exercises, voice or movement, and they really reap the benefits of and rewards of that improved self-confidence. So as much as possible as part of the treatment, it becomes very much about you are in control, you are in charge. However, that being said, there are certainly cases where family support and spouses and others can be helpful. And I'll let Heather open up and speak to those situations.
So we know that when people advance through some of the later stages of the disease, where there may be some difficulty with recall, with slowness of kind of bringing up the information, and maybe even some memory problems, it is very important for there to be someone to help them with that. There are some people who will actually need some help with cueing. There will be people who will still need some degree of physical help, but that degree of physical help may be actually lessened because that patient understands more of how they're supposed to move, and that person, who is helping them is also better capable of cueing that patient how to make those bigger movements and quality. So while there hasn't been actual research looking at people without help versus people with help, I can tell you anecdotally for my patients who I do see in the later stages, when they do have someone there to help them out, it is always beneficial. But I have worked with an equal number of people who we've been able to find ways to help them with using the videos, whether it's streaming the video or getting the DVD, of using the pictures and the exercises, of me actually doing a voice recording of me talking and cueing the person. So your therapist is always going to be willing to work with you to make that happen.
Thank you. Heather, this next question will be for you as well. I have significant digital numbness. Is there any remedy to lessen the impact?
Okay, so talking about digital, so we're talking about probably in the fingers and the hands, maybe even in the feet. I would say that the first thing that needs to be ruled out is you need to speak with your physician to make sure that this is nothing that's coming from a pinched nerve, that this isn't something to do with diabetes, some sort of neuropathy, issues with that. When we do get people who have numbness and problems there and everything else has been ruled out, we do find sometimes that it's simply the placement of how one has been sitting or holding oneself, where you can actually pinch off some of the feeling in the nerve. So we have had some improvement in people with learning how to make those bigger movements and then opening up things. Now that is not the case for everyone. It would really be on an individual level. But again, the first advice I would give you is you need to rule out that nothing else is going on there.
Perfect, thank you. Well, we are now at our top of the hour. And so again, if you come up with additional questions afterwards, please feel free to send those in and we are more than happy to answer those. I'd like to put a plug in for our next public webinar, which will be on LSVT Loud and LSVT Big Mythbusters, what you need to know. And that will be presented Wednesday, January 16th from 2 to 3 p.m. Eastern Standard Time. Please remember to take just a few moments, complete that survey as you exit this webinar. We thank you again for joining us. We wish everyone a very happy holiday season and a happy new year. Thank you.